Thank you, Lori. I think that is a very important message that we're going to take away and definitely be working on over the next bit. So the next section we're going to be talking about is how are we becoming trauma informed. So we've heard all this information today, so now we're going to give you a bit of background as to what has been happening thus far and what we hope to achieve collectively in the future. So, as we know, there was a lot of great work already happening. There are a lot of great individuals that are already doing trauma-informed care, trauma-specific treatments within the IWK, the Nova Scotia Health Authority, and the community. But we had a review, external review done of child and adolescent mental health and addiction services within Halifax in 2013, which really looked and said to us, you really need to look at this as a systematic approach. You are doing great work individually and with certain teams, but how do we do that collectively as a system? So the recommendations that they gave us were to really look at how, again, to be trauma-informed care, be more trauma-informed as a system, and how do we provide trauma treatment and how can we do that the most effective way. So from that, we, with the IWK and Department of Health and Wellness, worked together to figure out how do we do that? How do we make a plan to do this together? So we did have two initiatives that were going on. The first one I'll talk about is the one with the IWK and Department of Health and Wellness. So this was a project that went across Nova Scotia. We did consultations with people that worked in mental health and addictions across our province and really asked them what do they know about trauma-informed care, what do they want to know, how can we support them in their daily work. And from that, we got a lot of great information, which built some webinars and some practice guides. So really looking at how do you become trauma-informed, how do we take care of one another, how do we work with trauma-informed, how do we do trauma-informed care in different populations in different areas, and then supporting those with some practice written briefs, and they are they are on the Department of Health website, and they will be on our website that we're going to showcase today. So that's that piece of work, and also in conjunction with that, the IWK started to form an advisory committee. Initially, the recommendations were for mental health and addictions within the IWK and CDHA mobile crisis, but we really realized that within the IWK, it's not just mental health and addictions. Trauma affects everyone, as we're hearing today. So we really wanted, as an organization, for that to go across organizations, so within children's health, within women and newborn health, our operations and support teams. So we decided as an organization that this was important and we wanted to do this as an organization. So we formed our advisory groups and also reached out to many of you within different systems, different community partners, and said, how can we collectively do this together? So we ended up forming some advisory groups. So this is kind of our structure. There are 150 people, very dedicated, lovely, wonderful individuals that are so excited about this, and we're so happy to have them with us that are working on this. So we have the advisory committee, as I said, which is really looking at all the recommendations that come from all of these groups. We have a trauma-informed care project advisory team, which we'll get to show you at the end of the presentation, that's really looking at all the details of all this great work that's happening. And embedded throughout that, we have education, research, and evaluation, which Dr. Susan McWilliam is going to talk to you about in a minute. So we have our trauma-informed care model framework group. So this group is a group that's looking at education. So this is part of the group that helped with this lovely education event today and kickoff event. And we're also looking at how do we sustain that. And Sue's going to get into how are we looking at sustaining this. So this is a kickoff. We're all becoming more informed. How are we going to be more trauma-informed? But how do we build on that? How do we do that and sustain that as an organization? And then how do we move to, as I talked about, the other recommendation was trauma-specific treatments and services. So how do we move into that and make sure that we're providing the best care possible that we can? And so we'll talk about that in a moment. So the next group, and as Lori, basically half the day today and the presentation is devoted to staff. So in the same token that staff realize we want our own separate working group on this. So we really want to dedicate the time and the resources of a group that is looking at the psychological safety, wellness, and health of staff. So we have a group that's looking at that. We have a group that's looking at safe and secure environments. So we're looking at the physical spaces that we work in. We're looking at the emotional environments and how do we optimize those. And then we have, moving into more the trauma-specific, we're looking at early screening of trauma, assessment, and treatment. So as you can see, lots of work to be done. So we're going to highlight some of that. Some examples of the working group initiatives. For staff, some initiatives that we're starting up and that we will be doing over the next probably like 6 months for this one. We're doing a staff mindfulness training. With staff, we have 2 different kind of mindfulness pilots that we'll be doing with staff. Staff really said we want to learn more about mindfulness. We want to apply it. We want to be supported to do so. So we're actually doing that within an organization. We'll be starting that pilot in the next few months. Staff also told us that they really felt that we need to have a more formal debriefing process, and that after situations happen, it could be a critical event or, just something that happens on the unit that you want to have a moment to debrief, that we tend to do organizational debriefs, or we tend to say, okay, the staff okay, or the client's okay, we debrief with them, they understand what's happening, but we don't always take time to debrief and say, are you okay? Yes, we talked about how the, situation went, but we didn't talk, how are you at the end of the event, and how are you doing? Is there any supports that we need to provide for you? Is there anything that you need? And having that conversation. So really building that into our work life. We're also working on, within the IWK, is really a support kind of resource list for staff. So really staff said to us, we don't really know what's available, and Lori touched on this too. So with the Employee and Family Assistance Program, so that is one of them. How do we access that? What services do they provide? What other services do we have in our health center that we don't know? So really compiling all those lists and making them available for staff. So that's another piece of work that we're doing. Our website, we really hope, will be used on many different levels to support kind of a knowledge exchange, to have current resources up there for people to learn more about trauma-informed care, to look at our environments, our psychological safety. So all those working groups will have kind of almost different pieces of the website as we grow. And then we're also working on the Safe and Secure Environment Group is looking at a checklist, and we're hoping that's something one of the many things that we'll be able to share with everyone. So really looking at how do we devise a checklist going into an area that can help us to be more trauma-informed, because staff said, I don't really know what a trauma-informed space is supposed to look like. Can you help me out with that? So we're devising a checklist. So I'll kind of go over certain components of how we can be more trauma-informed. And these are some of the examples, just to give you an idea. So when we look around our physical spaces, we want to ensure that they're comfortable and safe and calming. We want to make sure that our furniture is up to date. The maintenance in the areas are up to date. We want to be looking at signage. We want to be looking at really framing it what you can do versus what you can't do. A lot of signs within our environments, sometimes tend to say, no violence here, no this or no that. We really want to frame it as to what you can do versus what you can't. And also looking too at our patient and family information. What information are we giving to them, and what messages are we sending? Are we saying, you can't do this here, you can't do that? Are we framing our messages that we're partnering with them on this journey? So we really need to think about language and how we frame things. Looking at our waiting areas, again, are they welcoming and friendly? We talked about that, and the maintenance up to date. Do you have information? This is a big one that staff brought to our attention. So do you have information, say a patient is waiting in a room or a client's waiting in one of your rooms, and it's basically either a staff procedure or information for staff, and clients are reading that and being triggered. So really looking at what information we have. We may need to access how to do the procedure, but maybe it's something that we end up putting, kind of in our desk or kind of on the side there, so it's not kind of printed up on our walls. So that's another piece that clients and staff have brought to our attention. So really looking at that piece of it, providing culturally appropriate symbols of safety in the physical environment, because we all want to see ourselves in the environment. So really making sure that we do have different, pictures, of families or clients, different things in the areas that people can relate to, or symbols of safety. And artwork, really looking at artwork that we have in our areas. Is there artwork kind of calming? Sometimes within the literature they say that nature scenes are found to be more calming. So what are we displaying on our walls? Are they developmentally appropriate? If we have lots of little children, it might be different what we have as a picture for a little child versus an adolescent versus an adult. So really just looking at those things. And then, of course, equally important is emotional environment. So really looking at this group is also looking at how do we create great interactions that are kind, calming, reassuring, and really focusing again on those strengths-based empowerment pieces and being respectful, engaging around the client's and patient goals, and really having relationships that are honest, transparent, developmentally appropriate, and making sure that we're providing as much power and control, say to a 5-year-old as much as possible, which may look different than a 15-year-old. Really asking the question. We're not going to know unless we ask. So really asking them, what are your triggers? What helps, if you have a child that's in pain? What usually works when you're at home? Is there something we can do to help distract? Is there something that we can do to help the situation? Because you know yourself or your child best. And continually do that through the process. The other thing that staff mentioned too is really focusing on, we tend to get feedback when people leave our services, but we don't tend to always really check in as much as we may want to, continually seeking that feedback to saying, how's it going today? How did this go? Is this okay? Is there anything you need to do differently? Is there anything what are your goals? What do you want to work on? How do we kind of meet those needs? Are we meeting those needs when we find out what they are? So really that continual feedback to kind of help us work together and partner better. And again, the whole piece about recognizing a coworker, we all work with each other very closely and we get to know one another. And again, really helping each other as we move through this journey. So we're looking at now the other thing that we can do and that a group is looking at, and we actually have the poster down at the back, the purple one kind of says similar information on it, but really looking at language. So what language are we using in our daily conversations? Are we looking at when somebody comes in for an emergency room, for example, saying, what's wrong with you? Are we saying, what's wrong with you? Or are we saying, what happened to you? How did you cope? Because it's not what's wrong with you, it's what happened. So we want to really look at our language. And how did they cope? I mean, they may have went through something, that they say is very terrible and very hurtful to them, but they got through it and were able, to show their strengths in that situation. This person is being manipulative, so we may hear that in our settings at times. And really flipping that from saying, really, they're trying, to get their needs met the best way that they can. They want attention is another one. And again, they're trying to connect the best way they can. So unfortunately, maybe in the past, a child has had to either raise their voice or hit to get attention, when they just said to their caregiver, I need something, or cried or whatever, they didn't get the attention in the past, and they had to escalate. Now the only time they get attention is when they yell or when they hit the wall or whatever it is, and now they come to us, and they don't know any differently. So they come to us, and they, instead of saying, can you help me out with this, they start to yell to get our attention. And it's not until we really start to model that and really show them that, this is a way that you can interact, and we can try to help meet your needs, that they may start to react differently as we model for them. And they have poor coping methods. They may not have poor coping methods. It's all in how you look at it. Maybe a survival skill, maybe what they had to do to cope, to actually live in a life-threatening situation, that worked for them to live, so that's what they did. So it may not necessarily be a poor coping method, but something that they did, and we can also help them to learn additional strategies when we work with them. They'll never get over it, or they're permanently damaged. Well, we know definitely people can continue to learn and grow, and we can help them on that journey to recover from trauma. The other big one we found with staff across our organization and different organizations was that I shouldn't raise the issue of trauma or they will get upset. And really talking about trauma without forcing anyone to disclose, like if they're ready to disclose and want to have that relationship with you, that they feel comfortable. Letting them kind of share that with you reduces the stigma of them thinking like, okay, I can't talk about this. This is a shameful thing that I should feel guilty about and I don't feel comfortable, and kind of creating that openness and environment to share that will actually, will help them. So now we're going to have Sue, and she's going to go through our education plan, evaluation plan, and research. So welcome to Dr. Susan William.
Hello, good morning. Thank you all for coming today. It's really exciting to look out and see so many people and to have seen so much enthusiasm behind this project, so really happy to have you here today. I'm just going to talk a little bit about the education plan. This is a very brief overview, and then I'll get into the evaluation plan, the research plan, and then I'm going to talk a little bit about our logo, which you see here, and how we came up with that idea. And at the end, I'm going to give you a sneak peek to the website. So in terms of the education plan, we have, so as Holly mentioned, we have 150 people on our various groups, and so we have a model group in particular who have been working on the education plan, and they came up with a 3-tiered strategy for educating everyone. So really, the first level is sort of a general trauma awareness piece, and that is going to be offered to everyone. And a big part of that is actually this week in the kickoff event, so you're all here for that, and you're getting exposed to the first tier in our plan. So another piece of the general level 1 education plan is just a general awareness campaign that is going to be using things like posters. We have a Did You Know campaign that are emails that go out to our teams that just give little facts about trauma. Things like that. We're also going to be sending event reminders, that sort of thing, just a general awareness campaign. We will also be creating core competencies, and these will be tiered as well. So there will be some core competencies available for the level 1 education plan, and they'll be very general, but will help organizations get an idea about what sort of things we want their staff to learn in relation to trauma-informed care. And there have actually been some really great core competencies developed about specific to trauma-informed care by other organizations. So we're looking at those. I've spoken to a few different groups that have actually developed these, and we've gotten permission to use some of the pre-existing core competencies and adapt them to our own needs. We'll also be looking at the American Psychological Association has come out with trauma-informed care core competencies, so we'll be looking at those, for example, as well. The other piece that's going to be a big part of our education plan for Tier 1 is the website. We really want people to go to this website and use it as a resource. Right now, we've just started developing it, so it has a lot of great PDFs and videos and peer-reviewed journal articles and some definitions about trauma, that sort of thing. But as we move forward, we're going to continuously add content to the site and really make it hopefully very interactive with all of our partner organizations and make it useful for lots of different groups. In terms of future TIC education sessions after this week, we've gotten some ideas already about things that people really want to talk about and really want to learn about. So some examples are having cultural sensitivity. I actually put cultural sensitivity, cultural competence, and cultural relevance intentionally because different people use different terms and are more comfortable with the various terms. We want to have a panel discussion about this and about how to make trauma-informed care services across the province more culturally sensitive, competent, and relevant. We also thought about having a patient and family panel. We really want to hear about, we want a lot of our initiatives to be family and patient driven rather than just, having a after the fact focus group where we ask them about specific questions that maybe we've developed. We want to actually turn the tables and make sure that they're driving a lot of these discussions as well. So we want to do that. I think based on our last presentation, I think it'd be fantastic to have a staff panel at one of these sessions. Community partners panel. We'd love to have a panel where we have a bunch of different groups from various sectors, from various groups, topics related to trauma, discussing how it relates to their particular service and how we can all work together. And then we talked about having things like specific safe and secure environments panels, so maybe having a discussion about debriefing, specific to debriefing and how we do that. So really there's a lot of flexibility around what we can offer in the future, and we're very open to ideas from different groups about what they'd like to learn. In terms of other future initiatives, some things that we're going to be doing is our core team is actually going to be doing team-specific and community-based organization consultations where we can meet with different groups and talk about how trauma-informed care can be make sense in their particular setting. We will also be offering down the line Train the Trainer program for certain individuals, and that will be so that we have a few core groups of people that can actually go and do skill building within the community so that it's not just one group, but we actually develop a variety of different experts across the province. Within the IWK, we're looking for trauma-informed care champions so that we have at least one touch person in every team so that we can actually keep this rolling and build sustainability. We're also looking into creating TIC-specific staff orientation and onboarding modules so that as soon as someone's hired and they come to our center, they will actually start to learn the language of trauma-informed care on their first day or their first week. We are also going to be creating e-source or online modules, which will be used in-house but can also be used by community-based organizations that will talk about a variety of different topics related to trauma-informed care. And another way that we're going to be incorporating this is we're going to be building the trauma-informed care principles into our nonviolent crisis intervention training as well, so that we can really make some ground there, so that we can talk about things like de-escalation and all those various, how all those various elements can be informed by trauma-informed care lens. Okay, so now I'm going to talk to you about level 2. So all of the things that were on the previous slide are sort of options for learning and education that are open to everyone. At the level 2, we're going to get a bit more focused, moving more towards less trauma, well, it's still trauma-informed care environments, but it's also people that are more likely to be interacting directly with folks who have had a trauma experience. So this will be for designated mental health and addiction staff and then other identified individuals from community groups or different groups that are going to be actually receiving ARC, which is attachment regulation or self-regulation and competency training. So this is a framework that was developed in the U.S. by 2 clinicians, and they offer this as a 2 or 3 day training, and it looks at how looks at developmental components and trauma and resiliency, and basically can be situated to a variety of settings and how to make those settings more trauma-informed for the clients. We're also, as I mentioned in the last slide, we're going to be developing a level 2 core competency too, which is a little bit more involved than the level 1 core competency. And then level 3 will be specific training and supervision for designated clinicians who will be providing trauma-specific services, who will be working with clients directly on their trauma and trauma symptoms. Okay, so in terms of a sustainability plan, for evaluation, Community Connections, where Lori is from, they actually have a protocol for certification that actually has an evaluation plan and serves as like an external review. It has a template that tells you what indicators to look at within your service to see if you're becoming trauma-informed. So we're going to be following that protocol. We're also going to be doing an all-staff survey at the IWK once a year. We just actually finished running this last week, and it was a readiness survey. So as an organization, how trauma-informed are we right now before we even go on the whole adventure of becoming trauma-informed? Like, what is our sort of benchmark or baseline? So that was just completed, and that will be looked at annually so that we can measure change. We also will have a very brief team template that we'll give out, which is, I think, going to be really useful for sustainability in the organization because it will ask teams to consider just a few ways in which they can become more trauma-informed, what their ideas are around fit within their particular team, and what they'd like to work on with some timelines so that we can actually get action. The core competencies, as I mentioned, are going to be useful, and then we also will have some checklists that will be developed around emotional and physical safe spaces, so things to look for in your own organization, and those will go on our website and can be downloaded and used. In terms of potential future initiatives, as I mentioned, we'll be doing online education modules. We would like to eventually build in a performance review question. At the IWK, we get performance reviewed as staff, so right now it's just, there isn't a trauma-informed specific question on that tool, so I'd like to build one in. Also, in terms of human resource considerations, some groups have actually put trauma-informed care scenarios in their hiring or their interview guides, so that when people come into the organization, they can give them they can get a sense of how trauma-informed that individual is, and also use it as an educational opportunity to sort of discuss trauma-informed care. We're also looking into developing student training and research opportunities. And lastly, hoping to build a trauma-informed care curriculum, which will actually be given to students when they're in the health professions, so that when they graduate and come into our services, they will actually know the language of trauma-informed care and have an introduction to it. So lofty goals. We have a lot of plans, but all of these come from great ideas from our various 150 team members. There are tons of research opportunities associated with trauma-informed care, and so we're going to be looking at what we can do over the next several years. We're starting a benchmarking study right now where we're going to be asking other organizations who have become trauma-informed how they did it, and barriers, facilitators, what we can learn from those teams. We're also looking at a study that looks at what was done in terms of trauma-informed care work or trauma work at the IWK prior to 2016, and we're creating a narrative around that so we can really look at and celebrate the fact that a lot of great trauma work was done and has been done for a really long time. We're looking at a lot of patient and family-driven research projects. I want to do staff-driven research projects. We're going to be looking at seclusion and restraint prevention and rates. We're going to be collecting a lot of program stats and looking at how trauma-informed care may or may not influence some of those. We're going to be doing some screening research. Certainly there'll be some evidence-based trauma-specific intervention outcome studies later on when we really know exactly what we're doing in that regard. IT systems and trauma tracking. Trauma is often not tracked well in hospital IT systems, so we're going to look at ways to figure out how to do that better. And then also something that we've been asked about lately is creating TIC resources for newcomers to Canada, and so we're going to be looking at research around that as well. So this is our new logo. We just came up with this a little while ago, and Revolve Branding, which is a branding company in Halifax, have actually helped us with this. And we decided, our team was struggling over what tagline or what kind of message we wanted to send with our logo, and we came up with this one, and we thought it was strong because we liked that. We thought it was positive, It was validating. It can apply to anyone. It's very flexible. So we tried a few different versions of it. We thought your experiences matter to us. Your experiences as a teen matter. Your experiences as a nurse matter. Your experiences as a social worker matter. Like, it can be used in a lot of different ways. And we really like the flexibility of it being applicable to patients and clients and families, but also to staff. So we did a focus group with our advisory committee, and they agreed that they liked it as well. So here you have our trauma-informed care logo. And I hope that we can get some feedback from all of you on it as well. And we're very open to any ideas or suggestions for working with this tagline. Now I'm going to try to give you a very brief sneak peek at our website. And we have to actually go out to log onto it. Our website is launching today. I'm not actually even sure if it's live right now, but I have a backup. So I have the developer site that I can show you, so I can still give you a sneak peek. But just if you're trying to get it on your iPhones right now or on your smartphones, it may not actually be live, but it will be at some point today. And as we said, we want this to be a provincial resource. We want people to be able to go to this site, and it's going to be developing and evolving constantly. Okay. There are a couple interesting features that we've built into this. For example, if you're not a pink person, you can change the color. Everyone who goes into the site, there's actually, you won't be able to see it here because this is the development site. Oh, yes, you can. Select the color. You can, and we have a whole rainbow of colors that people can choose from. For whatever your mood is at the time when you're looking at these resources. Purple. If you look at the top, the icons, so if you go under About, we have some information on the mission and the vision. We have some background information on the project. Learning is a really full tab, so we put a whole bunch of definitions of trauma and stress, a bunch of literature that supports these. Trauma-informed care, same thing. Safe space is really interesting, like those tips about how do you make your spaces more safe. The assessment, screening, and treatment tab is pretty empty right now because our working groups are working really carefully on this. But as we develop all of our protocols for that, they will be information on those will be added into the website. News and events. Eventually, there'll be a blog type little feature at the bottom that will scroll, and it'll show you all upcoming training events, different things, and not just things that are going on at the IWK, but other groups who are doing events related to trauma-informed care can tell us and let us know, and we can advertise at the bottom of our screen for that as well. The resources tab is chock full of videos, PDFs. Here you see there's a nice filter option that allows you to go in and see what type of material you want to get. And then the contact us, of course, so that's our team contact, but also there is I want, need help option as well, so that we can direct people to emergency services and various resources within their community. There's a really interesting feature under learning that we might be able to just quickly show. We're still developing this, but if you, yeah, thank you, Jen. So we have a picture here and of this is what a non-trauma-informed space might look like, and this is very much an example, obviously, just to give people a few ideas about things that might not be ideal in a trauma-informed environment. And then so if you scroll through, you can sort of see all the things in our commentary on how those things could be made more trauma-informed. So for example, the computer screen that's tilted in a way that confidential information might be viewable by people in the waiting room. Obviously, that's a concern. An overflowing garbage can shows, that we're not necessarily taking care of the space. Some other, inappropriate reading material on the table. So if it's a kid's space and there's, a newspaper with a graphic image on the cover, that kind of thing. Just things to be mindful of as you walk through your spaces. And then if you click on trauma-informed space, it actually shows you another photo with some ideas for, this is what we think is sort of a nicer, more trauma-informed space. And there will eventually be little markers all over that explain sort of what the features are and why we think they're more trauma-informed. So as I said, this is a growing, breathing website that's going to be changing a lot over the next couple of years, but we encourage you to use it and share it, and give us your ideas about content in the future. And the URL is yourexperiencesmatter.com. And if you accidentally type in CA, it'll still bring you here.
And just for those who couldn't hear Jen over there, it will be available, we're hoping, by the end of the day at some point today. Yeah.
Is this going to link in through post?
No, it's a separate site because it is for anyone across the province, so we want to make sure it is accessible. Yeah.
All right. So we're just going to go back to the PowerPoint. Perfect. Thank you. Yeah.
Yeah, so we wanted to do some thank yous before we get into questions. But yeah, thank you. Thank you to Lori for being here and sharing her expertise with us. It's been really great. Thank you to the Department of Health and Wellness. Thank you to the IWK and the Nova Scotia Health Authority for their commitment on this work. Thank you very much to the Trauma-Informed Care Advisory and Working Groups. I mean, your work on this has been substantial, as you can see, as we went through the presentation today. And also to the co-leads of these groups. Each of those 5 working groups have co-leads, which are very instrumental in moving this work forward. Thank you to our system and community partners. Thank you to all of you and the ones that are on the advisory and working groups. To Revolve Branding for our lovely logo and website that you just saw. And thank you all very much for taking the time of the day and really recognizing that this is important and really telling us that you do also believe in trauma-informed care and hopefully really want to join us on this provincial journey to become more trauma-informed. The other special thank you we want to do is for all these lovely people in the picture that are part of the trauma-informed care project team that I talked about earlier. So Jennifer Jeffrey, Amy Jones, who was missing from the photo but still very important to us, Prasanna Kariwanza, Charlene Martel, Jennifer McCarran, Joanne Zevenhausen, and Sue McWilliam, who's standing next to me. So yes, thank you to this group because you guys are amazing to work with and very much embody trauma-informed care in everything that you do every day. So thank you. So yes, for more information, we will have our emails are up there. You can contact us at any time, and I think we're going to go grab the mics now to get some questions for Lori, myself, or Sue. So please ask anything that you're wanting to know or any clarifications, questions, ideas. Yes, we have some mics over at the side there, so if anyone needs them or is close, if you want to shout them out, I can repeat it if you don't want a mic.
Okay, I see a question. I have the on button on here. Okay, wait.
I'm going to just start. What I was really thinking about is that I've had the involvement with some schools recently with children that have had a great deal of trauma. And there are trauma-informed school websites that are also quite useful. And they might be a useful addition to your website so that when you have teachers look at it and have section in their own schools, it might give them additional information. So it's just a suggestion. I've discovered some of them, and the school appreciated them.
Yes, no, they're great. Thank you for mentioning that. Actually, in our audience, Judy Elliott actually was sending us a lot of those school resources, so we can definitely, I think we started to upload some, but don't have them all there yet, but it is they're excellent resources that are very valuable for the community and the schools and beyond, because they have great ideas we can apply everywhere. Thank you, Wade.
And I would like to add also that we do have some representatives from the education department and
the
school board sitting on our advisory committee. And we also have folks from working groups, and we also have people from justice and from community Department of Community Services and different sectors. So there will be resources and different discussions around those various
Yes, you have a next question?
This is a question for Lori.
Yeah.
And I'm working with child welfare, and certainly we feel that we do re-traumatize people a fair amount, and I'm just wondering if you've worked with child welfare and have you put some of these services and ideas into effect with child welfare?
Yeah. And we have worked with child welfare organizations. I want to give you one example. I was in Kentucky, and one of the groups in the audience was child welfare, and they said, choice sounds good, but we can't give them any choices. We've been mandated if we believe they've been abused, we have to take them out of the home. They have to go into a foster home situation. They have to go to school. They have to go to therapy. There are no choices. And I said, well, do you have more than one therapist on staff? And they said, well, of course, we have about, I think, 10 or 12 therapists. Could you give them a choice of what therapist they saw? And they said, well, I guess we could. It wouldn't be very convenient. We just do it. We assign them according to who has an opening on their caseload. And so they decided to really take this seriously. And they took pictures of all the staff people. They asked staff to write a blurb about themselves. And they gave the kids a choice. Do you want to see a man or a woman? Do you want to see someone who's older or younger? And the kids had a choice about what therapist they saw. And the therapists actually got into it, and it became a little bit of a competition. You know how oftentimes we don't want more people on our caseload, right? They were actually, it felt good that kids wanted to work with them. And giving them choice about, do you want me to meet you at school or at your foster home or here at the office? But how can we figure out how much choice, can we build into it? How can we give them information to let them know what is going to possibly happen? And build up that trustworthiness. Because I do know that sometimes we know it can be a bleak process, and we can overstate things or make promises that maybe don't come true. And what they found was that it was better to give them an idea what might happen rather than what would ideally happen. And to let them know that, to make the process as transparent as they could for the kids. And that really increased the safety and the trustworthiness that the kids felt. So those are some suggestions that I have. But I think that even, and what I often hear from, whether it's child welfare, sometimes the criminal justice system, that trauma-informed care sounds good, but we don't know how to put it into practice. And really want to encourage you that sometimes those are the systems where we have to be more creative, but I think the outcomes can be even greater. To be able to recognize, again, if we give people choice, if we're willing to hear their voice and help them to gain their voice, how much of an impact and a difference it makes in their lives and their recovery. And thank you. That was a great question.
Joe?
Oh, Rich,
Right there?
I just wanted to comment. Thank you. I just wanted to comment on the support for staff. So I work for a private company, and I go into businesses, whether they be insurance companies, Michelin plants, or whatever. And I do health assessments. And in November, any employee who saw me for a 15-minute health assessment was given $200 into their personal account to use to buy their gym equipment, to buy their gym membership, whatever they wanted. The next month, they could go online, do another half-hour program. They would get another $200, and they got incentives for their flu shots. And I mean, it's wonderful. And when I saw the population and the health concerns that they had, I thought, this is perfect, because most of them were men, high-stress jobs, high blood pressure was rampant. But I was thinking, in all my 39 years, if I had dropped dead at work, people would have just walked over me, right? Nobody cared about my blood pressure or, my cholesterol level or anything like that. And when I retired in 2013, my 800 hours of sick time just vanished. So, there's never any incentive for that. And when I first started at the IWK 18 years ago, I used to get a cake delivered to the unit, and that was in appreciation of little sick time used. And then they stopped that because of cost. So, a cake really wasn't very healthy either, but, it's just funny how, as nurses, as health professionals, nobody's supporting us. And yet we're just giving and giving. And I'm sure everybody here has worked overtime without putting in for it, and or has worked through your lunch or coffee break and never got any acknowledgement for it. And I really find that quite sad. So.
But what nice examples you gave of incentivizing taking care of yourself. And in some ways, it's too bad that we have to have an incentive to do it. But isn't it nice? And what you said about, being able to cash in those unused sick hours, that we're gonna show our appreciation and that we want you to be even healthier. And that's really, I think, where we want to go, and to recognize that. Yeah. Thank you.
Thank you.
I just wanted to comment on what I perceive as maybe a conflict between family-centered care and trauma-informed care in respect to my job on the birth unit. Patients come in as a couplet. It's the mother and the second parent. And if that second parent happens to be an abuser or causing some kind of trauma in that woman's life, it's never acknowledged, it's never addressed, because he or she never leaves her side. And because we are very family-centered, there's never really an opportunity to get that woman alone and address if she has any concerns, if she's feeling threatened, is she feeling unsafe in her home. So I don't know if that's something that's being looked at.
Yeah, I think that's a great point. I think it makes us question, how then do we have that opportunity to talk to that woman, to say, do you feel safe? Are you feeling safe? Do you want this person here? Do you not? This is what we're hearing or reading or whatever, and how do we do that? So I think it is a discussion on how we can do that as an organization in a better way. So yeah, I think you for bringing that up. I think Sue.
And this is a great example of the need to have team-specific consultations around trauma-informed care, because Holly and I only work in one small team, and we don't know about all the unique nuances and issues that happen in all the other teams. So I would suggest that in this particular situation, like with your team, when we were working with you, we would create a bit of a working group, and we'd start to talk about those key issues and try to figure out solutions as a group, right?
And I would add that it would also be part of the trauma screening and assessment that you do. I live in the state of Maryland in the United States, and it's actually law that our primary care physicians and OBGYNs have to ask the question when they are evaluating a person, do you feel safe at home? And it is a part of every, and that's a confidential visit with them, so that they can start that discussion about safety. And so how can we build that into practice? And I don't think that it has to be, a law. It can be good practice and part of that trauma screening and assessment, that question is asked. And then you can come up with strategies, because she might not feel safe excluding that partner. Then how do we work with that and help her, knowing that she's doing it possibly under duress?
Can I say one more thing? I'm also really hopeful that the website will become a forum for networking. So we're not constantly reinventing the wheel, but we're having these conversations with other groups who have similar issues, and so that we can start to learn from one another and see what maybe has worked in a similar situation in a different environment. I think there's going to be a lot of room for those kind of discussions. And looking at literature and all sorts of different things to find out sort of how other groups have tackled that very question.
Great question.
Hi, I don't have a question, but a comment. So first of all, I want to say thank you for opening this up to the community. And I really appreciate the way that you're involving the community in your whole model of development and moving forward. So I look forward to continued opportunities to do that. A comment, not just for you, but for everyone here. In the research that I've been doing and what I've heard you present today, although there's a mention of cultural sensitivity, cultural relevance, and there's a mention of historic trauma around different oppressions, I think one of the things that's really important for us to be mindful of is that those microaggressions and the systemic oppression is happening in the here and now. It's not just the history and the intergenerational trauma. We're dealing with those things right now. The trauma of racism and sexism and homophobia and heterosexism and so on are part of the everyday, both for workers and the people that we're working with. So there needs to be a way for the trauma-informed work to bring that more into focus as a central component and not an add-on piece. Like, I think that's really, really important. The absence of that is something that's, I think, very problematic for me around the trauma-informed work. And what I've seen, I haven't found anything in the literature that addresses that. And so there's a real need to do that. There's a need to do that now. And as certainly because you're moving forward with this in this time and in this very collaborative way, then that journey needs to recognize the structural oppression, how that contributes to trauma, and what responsibilities we have to address that. Thank you.
Thank you.
Yeah.
Yep.
Anything else from anyone?
Yes.
Oh, yeah.
So thank you very much for your time and attention today. It's greatly appreciated. The slides will be available on our website also, and we will be recording this, as you know, so it will be available. And if you could please just put your evaluations in the glass kind of looking box, which is not glass, plastic, I'm sure, at the back of the room, that would be greatly appreciated. Thank you so much for your time and attention.